Yes.
Yeah.
So Dr. Ramley, thanks for joining us for our monthly implementation science series. I will introduce the speaker and then we get started. Dr. Edmond Ramley, PhD, is an associate professor and the inaugural program director for design and implementation sciences in the Department of Health and Wellness Design. He's also the interim director for the Center for Health by Design at Indiana University, in the School of Public Health. And he's also associate director for the CTSI at Indiana University for Implementation Science. Dr. Ramley's research program develops and tests innovative methods for the human-centered design and implementation of system interventions to improve health outcomes and care experiences among older adults and patients experiencing multiple chronic conditions in ambulatory and long-term care settings. Dr. Ramley's 15 years plus of research on organizational and digital innovations produced effective and broadly implemented solutions that reduced translational gaps in chronic care and prevention, for example, for blood pressure control or smoking cessation interventions. Dr. Ramley's research has been supported by federal funding from National Institutes of Health, NCATS in particular, and AHRQ or ARC. And he regularly serves as an ARC National Scientific Grant Review Study Sections and special emphasis panels. He is also the associate editor for the Journal of Human Factors in Healthcare, and he will talk to us today about the intersection between implementation science and systems engineers, human factors engineers, his areas of interest, and these kind of eclectic areas of overlap between these specialties or fields of study. Welcome, Dr. Ramley.
Thank you very, very much, Lavi, for the invitation. Thank you for the introduction. And my hope and goal for today is that by the end of our time together, you'll see these areas as complementary as well as eclectic. I have prepared for you a set of activities that I'm going to invite all of you to participate in actively. So those of you who have devices with you will have some opportunity to copy some worksheets and work alongside me so that what you leave with today is more than ideas. It's going to be challenge by choice. If you want to just follow along and see what people put in the chat, you're welcome to do that as well. I'm hoping this can be as interactive as the hybrid format allows us to be. So thank you for having me. And I spent a lot of my career in Wisconsin and have many collaborations still with Medical College of Wisconsin. I was at the University of Wisconsin in the College of Engineering. That's where I trained with my master's and PhD in industrial engineering, specializing in health systems and human factors. And then I did my postdoc at the CTSI at the University of Wisconsin in implementation science. And my first faculty position before coming to Indiana was in the School of Medicine and the Department of Family Medicine in Wisconsin. So long history in Wisconsin and lots of respect for what you all do at Medical College of Wisconsin. I have collaborations with Catherine Flynn and John Neuner, among others. So I wish I could be with you in person. I do miss Wisconsin, but this is the next best thing. And when Tavi and I spoke about opportunities to support your training programs in implementation science, he was generous to share a list of previous speakers that you've had, and I was able to go in and see some of the different presentations you've had. So I wanted to make sure that this was building on some of the great presentations that you've had before. So I know you've had an introduction to human factors. So for those of you who haven't had a chance to watch that video, it's a fantastic presentation by Dr. Lisa Popowski. You've had an introduction to design thinking. Again, you can go back and see that presentation. What I'm hoping to give you today is some of the connectors. And of course, you've had many presentations on implementation science. What I'm hoping to give you today is some of the connections and bridges between implementation science and user-centered design, whether you take a design thinking approach or a human-centered design approach, or in my case, I'll show you the lens from human factors engineering. So without further ado, let me go ahead and share my screen again. I know I shared it before, so I know it's successful. It does look like, at least for the people in the room, you will not be able to see my face, as far as I could tell when I share my screen. So as we need to, I might stop sharing my screen if we have some interaction and questions that people have. Sounds like a good plan. I can see people in the room. Maybe I can get some thumbs up. All right, yep. Great. I wish I could be with you again. I'm a very in-person person, but 10 years of improv theater and improv workshops, I'm okay with adapting on the fly and turning this hybrid experience into a good one for you all.
I think we should still be able to see your face when you put your presentation up too.
Great, thanks for that. Yeah. For that live feedback, for being my local sensor.
You got it.
Yeah, don't take your shirt off yet.
Maybe not today. Okay, so and I can no longer see you all in the room just yet. So let me just readjust myself because I want to be able to see at least the folks. Yeah, okay, I can see you. I can see that you've got my slides and you're telling me that you can see me. Fantastic. Let's get rolling. So I named this presentation Implementation as a Design Journey, Bridging Human Factors Engineering and Implementation Science. Bridging these two fields has been a long-standing interest of mine, and I've worked on the bridging from both perspectives. So if you think of a bridge as 2 points that need to be connected by something that we can cross back and forth. I've delivered a number of workshops for human factors audiences, introducing them to implementation science, and a number of workshops for implementation science audiences, introducing them to human factors. And for you all, I see you as an audience who's beyond the beginner level from both perspectives, at least for those of you who have had the opportunity to participate in this series previously. And since you have everything recorded, you can always go back and work through. So I wanted to go a little bit beyond some of the basics. And I always like to start any engagement like this one with sharing where I think you're coming from, so that we can calibrate. So at least for folks in the room, and I think we can try with our hybrid folks to do some thumbs up and some kinds of reactions. So I'm assuming that most of you or all of you are coming in as people who are interested in doing clinical and translational science. Can I get some reaction of who kind of self-identifies that way? Okay, and maybe in the online as well, if folks want to. Okay, hey, Catherine, good to see you. And okay, Noel, Martin, fantastic. Okay, so I see some folks are not self-identifying as clinical and translational scientists. So just to help me calibrate, what other identities do we have in the room that don't fit under that broad umbrella, whether it's in the live room or online? You can put it in the chat, perhaps. Anyone wants to share about some identity you identify as other than clinical and translational scientists? Okay, well, my assumption then is that perhaps some people are coming from the health system side and have clinician roles, leadership roles. Perhaps some people are coming in not necessarily as clinical and translational scientists, but maybe coming in with with background in some other form of research, such as great thanks for that, Dr. Harris. And maybe people are coming in from community organizations. So this is going to be relevant for everybody. My assumption about your intents and your motivations and your goals is that you are interested in some way in the uptake of health interventions, and you might be at different places in the journey of any one intervention. You might also be have multiple interventions that you care about where you're at different places in each of those. Be it that you're designing something from scratch where you don't have anything yet and you're trying to understand the needs of the people that you're designing for, or you have started developing some kind of prototype or some kind of intervention, or you might be taking an intervention that's already shown to be effective, that's evidence-based, and you are working on adapting it using a variety of approaches, community-engaged participatory research, or participatory co-design, or user-centered design. You might be testing the efficacy or the effectiveness of an intervention using trials, using observational designs, using quasi-experimental designs. And you might be working on disseminating an intervention that's already been tested at some level, or you might be working on implementing it. And one of the differences between dissemination and implementation is more active, trying to change behaviors. Dissemination tend to be about spreading information about an effective intervention. It's more of a spectrum than that, but that's a helpful way to think about it. So perhaps those of you who are at a device, we can take a moment and throw in the chat where you identify here at the early stages, the middle stages, or the late stages of designing, developing, adapting, testing, or disseminating and implementing, just so that I can have a quick sense in here. So more the first two for Dr. Flynn, early stages for Dr. Harris. What about in the room?
Early.
Early?
Lots of early here.
Lots of early. Okay, great. The great news, designing, adapting, testing from Dr. Schmidt. Okay, great. So the great news is you can never start too early thinking about implementation. As those of you who are participating in this series on a regular basis know, implementation is not an afterthought. We begin with the end in mind, and it is really a journey, as I hope to convince you by the end of the day. And if you're already convinced, then I hope to give you some practical ways to work throughout that journey. So my plan for today, again, is going to be very interactive. And I realize that sometimes you come into these, you're maybe during your lunch hour and you're hoping to sort of tune out and do some email. Feel free to do that. If you'd like to join us, challenge by choice, this is an opportunity for us to have some interaction, which I'm happy to continue conversations afterwards. You can connect with me by scanning the QR code or by directly going to Linktree /admin.ramley, and you'll find a variety of ways to connect with me. The main one being LinkedIn, both my personal page, my program page, and I also recently became the interim director for the Center for Health by Design. You'll be able to find the website there. So our goal for today is really in two thrusts. One, implementation matters and design matters, both hand in hand, and I'll give you some orientation on the way I see them bridging. And then we'll get into practical ways of looking at implementation problems from a design perspective and beginning to come up with design solutions. By the end of today, you will be able to start that journey wherever you are already. you will not be able to complete the journey, but I hope to give you sufficient tools wherever you are in the journey to take it to the next step. So implementation matters. You have seen many presentations in this series that really highlight the importance of implementation. The fact that you're here means that you believe implementation matters. And of course, there's a variety of articles you can find out there about the importance of implementation and the gap that we have in implementation. We often talk about, I'm sure many of you are familiar with the 17-year gap. 14% of clinical interventions that are already shown to be effective post-RCT ever make it into practice. And even for those 14%, it takes 17 years on average. And when you think about it as an average, think about different subpopulations for whom it might be taking even longer. So implementation clearly matters. We know this is a problem we need to solve. Otherwise, we wouldn't have an entire field of dissemination and implementation research, an entire field of implementation science, and we wouldn't have so much focus from CTSIs on implementation. Clearly, we can leave it at that. We can say we already know how to design effective interventions, how to test them with randomized controlled trials. We have a very large evidence base. Let's not restart from scratch. Let's take what we have and try to close those gaps after the thing has already been shown to be effective and move on from there. And in a lot of cases, we have to do that. In a lot of cases, you won't be able to go back to the drawing board. So part of what I'll show you is that design matters at any stage. Even if you already have an intervention that's gone through 7 RCTs, it is evidence-based. It has been adapted in a number of populations, and yet we still don't know how to close some of the implementation gaps. You can take a design lens at that stage without necessarily going back to the drawing board and redesigning the intervention. And of course, if you are at an early stage, which many of you are, design matters even more so. So the 17-year gap is a useful way to think about the gap between knowledge and practice. Another helpful way to think about it is, even if we assumed that we had an intervention that was 100% effective, it's gone through the most rigorous randomized controlled trial, and every single patient who received the intervention had 100% improvement in their outcomes. Of course, that's the ideal case. It never is the case. But even if we took that as a thought experiment, by the time the intervention reaches eligible patients, which it may be that a lot of patients who could benefit from an intervention that is effective aren't even given the opportunity, maybe because of language barriers, maybe because of geographic location, maybe because of a variety of factors. Let's say only half of patients who could benefit from that ideal intervention receive it. And half of the sites who could be delivering the intervention, or half the providers who could be delivering the intervention, adopt it, decide to begin implementing it. And then half of those implement it with fidelity. And then half of those maintain it over time. When you multiply that many 50% by 50% by 50%, the 100% gets diluted to 3% in fact. So even our best interventions are actually pointless if they are not used. And you can see how use is reflected at various stages of this implementation journey. And we're going to bring the design journey into it in a moment. But used by being offered to patients, used by being decided to be implemented by settings and providers, used with fidelity, used over time. And so many of you are probably familiar with the RE-AIM framework, which is where these stages come from. So effectiveness research is where we are focusing on, we have interventions, do they work? Do they achieve the outcomes that we intend for them to achieve? And then the other outcomes from the REAIM framework are we reaching the people we are intending to reach and who could benefit from this effectiveness? Are the people and places who could be implementing this effective intervention deciding to implement it? Are they doing it with fidelity, and are they maintaining that? So how well does the intervention work, and how much and how well do the people and places who can bring it to practice do that? Now, we're talking about use at these various stages. And if we don't have use, even the best intervention is not going to be impactful. And it turns out there's, as you know, an entire set of fields that is dedicated to design from a user-centered perspective. And you have already heard about design thinking, which is very much a lot of approaches to human-centered design are different ways to think about the same thing. I'll bring you the human factors lens, which you've already been exposed to in a previous presentation. I'll focus it for you here today on design as it relates to implementation. Because at each of those stages where we have a voltage drop, where we lose, in this case, in this thought experiment, half of our population that we could impact, half of our impact, each of those stages is associated with some user needs that were not met. Broadly speaking, right? Different users. We have the people who benefit from the intervention. They are users of something. We have the providers who are delivering portions of the intervention. They are users of something. We have the decision makers at various levels of organizations and policy who are users of something, right? And then ultimately the broader public, the society is using something. So we can think broadly about users and user needs and think about, by losing some of our impact from the best possible intervention to 3% impact, even in these very favorable assumptions here in the thought experiment, there are some users. Who are they? At the various stages that needed something that they did not get. What is that? So for those of you who are in the early stages, this is a very exciting time for you to be, because you can begin thinking about these things up front and avoid getting in a situation where the needs end up unmet. You can be thinking up front by anticipating the need and try to tailor for it. So that is one mental model that helps us think about the implementation journey and different places in that journey that our design journey can latch upon. And we did that by connecting the implementation outcomes from the REAIM framework to the concept of use and users from user-centered design, and my presentation from the human factors engineering perspective. So we'll have the opportunity to dive into this together to do some practice. For right now, let me give you an example. So some of our colleagues in implementation science have bravely presented this case of very strong, rigorous, evidence-based intervention that was, by all hypotheses, supposed to have a fantastic impact on the care of primary care patients with opioid use disorder, with major depressive disorder, with post-traumatic stress disorder. So this collaborative addiction recovery care intervention had been evidence-based and was being tested for implementation among FQHC patients in the Southwest of the United States. Unfortunately, it only reached 3 out of 1,000 patients that it could reach, right? So it's even 10% of 3%. So very minimal effects for an effective intervention to have very minimal impact. And some of the barriers that were identified by this group of colleagues is that the intervention was too burdensome. So that already has some unmet user needs and context implications, right? Too burdensome for whom, in what ways? Also, there was staff turnover, which means that there were some people whose needs were being met when staff was at a steady level and stopped being met. So it's not just the needs supported by the intervention, but also the needs that are met and not met within the context, within the system. There were some privacy concerns. Again, someone's needs were unmet. Lack of internet access, need for access to technology unmet. And then clinicians did not follow up, which oftentimes is associated with a variety of needs that are not being met. We know that our clinicians are doing a lot of amazingly important work with very little time, with a lot of burden, and one of the data points, I think it was from the United States Prevention Task Force, that if a clinician was going to implement all of the prevention guidelines, it would take something like 9 hours for just preventions, right? So there's already needs that are not being met, which means that even effective interventions can fail to be implemented because of unmet user needs. So my hope is that by right now, if you already were convinced of the complementarity between a human factors approach to design and implementation science, if you are already convinced, now you're very excited and you're ready to roll up sleeves and get going. If you weren't convinced, I'm hoping that by now you are convinced, and or at least you are intrigued. So how are we feeling? Let me see if my sensors in the room can give me some thumbs up or ask me some questions. I see one thumb. I see a thumb online. Yeah, okay, a bunch of thumbs. Great. Okay, so you're all ready to go. If you have some questions, things you want me to double click on, sort of unpack, at this stage, feel free to throw them in the chat. We're gonna keep rolling. So we talked about why implementation matters, why design matters in the context of implementation. Now we're going to talk about how can we frame implementation problems from a design perspective, and how can we bring solutions from a design approach to those implementation problems across that implementation journey. So quick overview. I know a lot of us here in the room have been exposed enough to implementation science, might have already seen this slide from Jeff Kern, or have been exposed to the idea of thinking of the intervention as the thing, but I'll do it as a quick level setting. So there's this very useful way of thinking about the distinctions that are useful in implementation science from a very non-scientific language perspective, is that whatever it is you're implementing, whether it's an intervention, a practice, an innovation, a technology, a pill, that's the thing. And effectiveness research is about whether or not the thing works. Implementation research is how can we best help people and places to do that thing? The nurses, the MAs, the providers, the informal caregivers, the patients, the hospitals, the primary care clinics, the long-term care settings. How can we help them do that thing? And implementation strategies are those interventions that we are using to try to help people and places do the thing. And to disambiguate them from clinical and health interventions, we call them, rather than calling them implementation interventions, we call them implementation strategies, so that we have different terms as a helpful way of distinguishing those different concepts. Which, by the way, it can be useful to not make those distinctions. And some of the approaches in human factors engineering look at the whole thing as a system and don't try to separate intervention from implementation. It can be useful, of course, to make that distinction. And so when we are making that distinction, we talk about the implementation strategies as the things we do to help people and places do the intervention, the clinical and health intervention. And then just like we have intervention outcomes, which is the effectiveness, that did it work, we also have implementation outcomes. How much did people do it? How well did people or places do it? And so just like Jeff Curran took some of the key concepts and put out a very brief, very nice paper to distill it into lay terms, we did a similar thing where we took a really nice logic model from J.D. Smith and colleagues, which is cited here below, called the Implementation Research Logic Model, that I highly encourage you to go and read that paper. And they have a really nice set of additional files, like 8 of them, with lots of worked examples. So the Implementation Research Logic Model is a really nice deep end of the pool if you want to unpack things and unpack some of the mechanisms and some of the different layers of this. But we took it and distilled it to just the key concepts in our Implementation Science 101 paper. So we have the intervention, that's the thing. We have whether or not it works. That's the intervention outcomes. The main one being the effectiveness of the intervention. There might also be some service outcomes. And then we've got the context that gets in the way or helps the intervention be implemented. So that's what in implementation science we talk about as barriers and facilitators to implementation. Is always a specification I like to add, because elsewhere outside of implementation science, we use the words barriers and facilitators a little bit more broadly. So in human factors, we talk about barriers and facilitators to successful work performance. So I, as a person trying to achieve some goals, might be able to achieve them well or not, with potential positive outcomes on what I'm trying to do, trying to help a patient, and positive outcomes for me. I have good well-being, I'm safe, and so on, or not. So implementation barriers and facilitators are, in a sense, a subset of more broadly barriers and facilitators. And then to address these implementation barriers and facilitators in the context, we have some things that we do, some implementation interventions that we call implementation strategies, and themselves are interacting, of course, with the intervention and have an influence on their own outcomes, the implementation outcomes that can that have to do with how well and how much people used the intervention. So the intervention, from a human factors perspective, it's helpful to think about it as any actions that are intended to improve clinical or health outcomes. Now you can tell me, well, there's a program, there's a technology. It's not really actions, but the technology is leading people to take some action, right? So maybe it's a clinical decision support system, and that's the intervention, and it's leading the clinician and the patients to have some shared decision-making conversation and take a certain course of treatment action. So distilling the intervention to what are the actions to improve clinical or health outcomes, and then what are the other components that need to support those actions. And that's related, for those of you who are familiar, to the notion of core functions of an intervention. What are the things that the intervention helps achieve? And then it can take different forms, functions and forms, from Brian Mittman and colleagues. So that's the intervention. And then, of course, the intervention is going to have some effects or not. And those of you who are in the early stages, at some point you're planning to do some pilot testing, some effectiveness testing to determine whether or not the intervention has an effect on the endpoint of interest, be it a clinical outcome or be it a health outcome or both. And you might be taking an intervention that already has effective intervention outcomes, and you're trying to determine whether when you adapt it to a different population or adapt it to a different setting, it's still effective. So that's the basics of effectiveness research, is an intervention and its outcomes. And then, of course, because of that implementation journey that showed us that even the most effective intervention could have 3% impact in the best assumptions, it's important to look at implementation outcomes. And those are the effects of the actions that we took to help implement the intervention. In a controlled trial, those things are very tightly controlled by the study team. But when we go beyond the trial, those things are going to be more subject to whatever is happening operationally. So being able to, even in an effectiveness trial, to describe what you did in implementing your study protocol can be very helpful down the line when someone is taking this effective intervention and trying to put it in the real world. And there are hybrid study designs for that you can find links to in our paper, hybrid effectiveness implementation study designs that help you look at both in parallel. And then, of course, these implementation outcomes are coming as a result of the barriers and facilitators in the context, which with our actions to implement the intervention, we're trying to overcome barriers, and we're trying to amplify or leverage facilitators so that our implementation outcomes are as good as they can be in that particular context. So our paper has a lot more than this to unpack the different key articles that you can go in to help you really get into the different aspects of those different key components. And I include this here because I know a lot of you are probably working on grants, and I know when I'm working on grants, it's helpful for me to have things I can cite. So this paper has a lot of the well-established, well-recognized frameworks and key seminal articles and how they relate to the different components. And you can even use this as a foundation for your conceptual framework in your paper, and then you'll have a ton of citations to build on that. If you take nothing else but 3 core frameworks in implementation science, you're probably already familiar with them. The consolidated framework for implementation research, which relates to context, the outer setting, inner setting, intervention characteristics, individuals characteristics, and implementation process. The expert recommendations for implementing change, which has 73 and counting implementation strategies across 9 clusters. And then the re-aim framework, which I already shared with you, that you're probably familiar with already, and I shared it with you as a way to think about implementation as a journey that we can latch on with our design journey. There are, of course, many others. There's, by last count, I think something like 140 theories, models, and frameworks in implementation science. And some of my colleagues like to joke that frameworks and models and theories in implementation science are like toothbrushes. Everybody has one, and nobody wants to use anybody else's. But if, for the purposes of a grant, you probably can't go wrong with a combination of these. There is another context framework that you might use in concert with re-aim, which is the PRISM framework that is now integrated with the re-aim framework. But these are very well recognized. You can start there and go beyond. So going back to our design journey. So we talked about how there's this implementation journey and we keep losing impact along the way. And then I showed you this way of thinking about the different levers that we can pull to try to influence those different impact stages of impact loss along the implementation journey. So for each of those, we can think of users who have some unmet needs, right? So if the intervention did not have the effects intended, that means that some of those patients who were in the target population, and even though the randomized control trial showed that the intervention is effective, on average, some of the patients were not on the right side of that average, right? So some of their needs, whether they're biological needs, whether they're social needs, whether they're personal needs, whether they're a variety of other needs, were not met as far as the outcome is concerned. Of course, the intervention itself, right? The actions that someone needed to take. A clinician needs to take an action, a patient needs to take an action. Some of the needs that they had to want to and be able to take those actions successfully were not being met. Similarly, with the implementation outcomes, some of the things that someone from the organization or from the research team, in a lot of your cases, had to take some actions to help with the actions at the intervention level, and those didn't meet the needs of everybody who would be the recipient of those actions, be it a nurse or being a physician, or be it a healthcare leader, or be it a patient or an informal caregiver. And then similarly, the context is really helping us unpack those unmet needs at different levels. The unmet needs of users, the unmet needs of users in their context. And in a moment, I'll show you how we can think of user needs and context, not only from an implementation-focused lens, but from a person-focused lens in human factors engineering. And then, of course, all of that comes down to the linchpin of our main lever is what are the things that we can do to help bridge those gaps. But you can see that at any stage of the design journey that you are, there are levers you can pull. The last resort is the implementation strategies. But you are in a very enviable position, is that you're starting early and you have way more levers than that. So you've already been exposed to design thinking. This is one way of thinking about a design process, from framing, where we're going to diverge and then converge. We're going to frame, we're going to identify problems, we're going to generate some solutions, and then we're going to prioritize, select, prototype, test different things rapidly, rather than waiting 5 years for a trial, and then evaluate rapidly. And so that's a design process of many. You've been exposed to at least one other. And then thinking of users in context, we can do it from an implementation-centric perspective with the Consolidated Framework for Implementation Research, CFIR. We can also do it from a human factors perspective, and this is a framework of the work systems model. I have a citation for that in a few slides. But essentially what it says is that context has nothing to do with interventions. Context has to do with people. And even this is agnostic to interventions. This is people are doing work, and that work is alone or in collaboration with others, and has physical, cognitive, and socio-behavioral dimensions, and has some outcomes, desirable or not, proximal or distal, and that work is shaped by interacting components in the system. All of the other people around you that are doing work that interfaces with your work, the characteristics of the tasks that you are completing as part of your work, the tools and technologies available to you, within an organizational setting with its norms and culture, within an internal environment that might include the physical environment and the external environment that might include financial, regulatory, and policy landscapes. And of course, critical incidents like a pandemic, right? So all of these things are focused in this model of the context on people doing work. And so thinking of context from two perspectives, people doing work in context and having needs. And of course, what we know with CIFR, which is an implementation has barriers and facilitators, that can be complementary. So the arrows here indicate that you can iterate between the design process and this systems approach as often, as quickly as you can. And ideally, you do it quickly, fast, often, and cheaply so that you don't get surprised after 5 years of an RCT. You find ways to do it with local funds, with pilot funds, to do some of that rapid testing. And you can see that any of those 6 steps of a design process can benefit from this systems lens, whether it is for framing the broader issue we're addressing, identifying problems, and so on. So I'll give you a quick example from our work where we conceptualized an intervention as a system. So we had some tasks, some evidence-based tasks that we wanted to accomplish in a specialty setting to connect patients back to primary care. We wanted to remeasure high blood pressure. We wanted to offer follow-up if the second blood pressure was high, and we wanted to connect patients to order follow-up appointments by ordering follow-up appointments to primary care. So check, advise, and connect. Those are the tasks. They have some characteristics. In order to support them, we had some technological components of the intervention, like a reminder with a best practice alert in the EHR to check high blood pressure, a reminder, in this case, to the medical assistants to offer follow-up, and an order set to be able to order follow-up in a way that goes to the scheduler to helps the patients. And of course, for the people, not only are there the patients and the medical assistants who are engaged in this process, there are people aspects at the implementation level as well, right? So we needed to engage our medical assistants by tailoring to the different clinics through co-design sessions with them to help them feel a sense of ownership and to identify barriers and address them rapidly, which also leads to an improved sense of self-efficacy, not only through engagement, but also through training and through giving them feedback on a monthly basis on their rates of accomplishing these tasks. And then in order for that to happen, the organization needed to have buy-in for the protocol at different levels. When we talk about buy-in, it's not just top leadership. It's top leadership, it's clinic managers, it's frontline staff, and having a champion from the medical assistants in each clinic be in support was important. And then that allows capacity building for QI. And one of the other things that we had to do in terms of the protocol buy-in is we needed to get a delegation protocol for the medical assistants to be able to do some of those orders. And then all of that goes on physically. The order goes on the after visit summary, as well as the physical layout of the clinic is going to influence whether or not the patient will stop by the checkout desk for scheduling follow-up, and then also a brochure that they can take and hang on their fridge. Of course, this doesn't address every single unmet user need, but it gives you an idea of how to think about our potential for dropping impact from the perspective of people and their needs and context. And of course, we doubled the odds of timely follow-up, and we maintained that, and we even had a better impact for some of our patients. So now it's time for us to do some practice together. I'm going to pause on this slide for one moment to see what clarification questions we've got, and then I'm going to guide you into some interactive practice. Okay, so I just counted 20,000. So hopefully, if you wanted to, you still have the opportunity. I know that sometimes waiting in silence is a little bit awkward, but I found that with a long enough silence, sometimes people jump in. But maybe we'll have opportunities to do that as we start getting into the work. So here's another QR code. If you go there, you'll be able to copy worksheets on a Google Slide document that you'll be able to copy to your own workspace and work through. Even if you're not able to go there, you'll be able to follow along in the chat. If you can, if you have a device and can go to the worksheets, there's some ways they're structured that will help you go step by step through this. So what we're going to do for everybody is after you use the worksheets, you're going to put your responses in the chat. And even if you're not doing the worksheet, there should be enough information on this slide to help you do the minimally viable practice. So first, think through an intervention that you care about and try to describe it briefly. Try to be thinking about who's doing what, right? We talked about intervention in terms of actions and the things to support those actions. If you can't get it under 7 words, that's okay, but sometimes having a boundary helps focus our mind. There's some science on that. So see if you can describe an intervention that you care about in under 7 words. I'll put about a 1-minute timer to take us through that. And then when you're ready, you can put that in the chat. Thank you, Dr. Flynn. Okay, so you can go ahead and put in the chat some information about an intervention you care about, whether it is one that you are working on or one that you're aware of. Distress screening and subsequent support for patients. Okay, great. Great. That is actionable. There's a specific action taking place. There's actually 2, right? It's screening and support. and we know for whom it is, and presumably you have some ideas of who is going to do what to support those patients. Thank you. Yes, definitely feel free to come back to the video and feel free to reach out. So social support for youth experiencing trauma to improve mental health and well-being. So our intervention outcomes are related to mental health and well-being. Our population is the youth experiencing trauma, and the intervention is some kind of social support to be specified as actions taken by someone. Reducing blood pressure, for certain patients in a certain program. Okay, great. And so what is the intervention though, right? So this is the target, this is the goal, this is in a sense the intervention outcome is to reduce blood pressure. There would be some kind of intervention, right? So is it advising patients on the need for blood pressure follow-up? Is it medication management? What is the intervention? So, okay, so those are some great examples. Let's think through together now who, as far as the effectiveness of the intervention is concerned, who are some of the follow-up and screening? Great, Dr. Harris, that's exactly a good example of specific intervention targets. And then you might think of what are the intervention core components that move the needle on those targets. So as far as the effectiveness, thinking through the intervention that you put in the chat, or if you couldn't think of an intervention, feel free to take one of the ones that someone else put in the chat and think through who is at play in whether or not the intervention is effective, and what might be their unmet need or needs that leads the intervention to not be effective. So who and what? Starting with just the effectiveness. And you can go ahead and put in the chat. Or feel free to unmute and jump in and talk about your intervention if you'd like. Right. So the CBO might not have the capacity to implement the intervention. So that's actually a very real unmet need that would get in the way of them adopting it and get in the way of them implementing it. They might not even get to the stage of effectiveness at all. So yes, any of the implementation outcomes, if any of the implementation stages downstream of that journey, if they're not met, might interfere with effectiveness. But in terms of effectiveness, let's say you got to the point where the patient is being reached. At that stage, what might be some unmet needs that might lead that patient to not be effectively supported? So in the case of follow-up and screening, let's say we did screen a patient, but somehow the question that we were asking for the screening just didn't resonate with the patient, and we had a false negative or a false positive. In case of blood pressure, it might be a measurement error. It might be something with the equipment, right? Or it might be skill. It might be hypertension, white coat syndrome, right? So a variety of user needs, whether it's the person taking the measurement, whether it's the patient, might have a variety of needs that may interfere in screening not being effective. Similarly for follow-up. Okay, so then for reach, what might be some things that get in the way of the patient even being screened, or the patient even being offered follow-up? And those things might be related to some unmet user needs. Maybe it's the medical assistant is so busy and just forgets to measure the blood pressure, or forgets to remeasure the blood pressure, which happens very often in our observations where we shadowed 195 visits where medical assistants were rooming patients and taking their blood pressures. A lot of adaptations happen in the flow because of challenges in the setting. And the patient might also be running late, for example, right? And so we end up not screening. So there are some user needs that may lead to not reaching patients. Another simple one is the patient just didn't come into the clinic. It's a patient who could be benefited from our intervention, but they're not visiting the primary care clinic in this case, or the SDC program in the period where we're doing the intervention. So we didn't reach them. So you can think about those unmet needs. Are there things that we can do to address those needs? And to do that, you can use a variety of methods that are available to you, whether they're qualitative methods like interviews or focus groups or observations, whether they are having a patient advisory board, whatever methods you have available to understand users and their needs and what can help address their needs. And sometimes it's doing rapid testing and seeing what happens when you try the thing and what needs are unmet still after trying something low-key. An advisory board. There are different ways to do advisory boards, right? You can do an action-oriented sort of design board where the people on the board are actually co-designers and they're designing with you. It can be an advisory board that is a homogeneous group. It could be a mixed group of patients and informal caregivers and clinicians and nursing staff, for example. There are different advantages and disadvantages of having the groups together. It may lead to some power differentials and no opportunity to dive in deep into one perspective. Doing the groups separately and going back and forth can address that challenge. Also has its own disadvantages. In our work, we've done a combination where we have the groups meet separately and we alternate between them, and then we have them come together. So as far as adoption is concerned, you can see that now the people who are involved might be different, right? Because the person who is deciding whether or not that intervention is going to be implemented in this setting might not be the medical assistant, might not be the clinician, might not be the patient, might be a committee, might be a series of committees. When we were implementing Quit Connect, which is our tobacco cessation intervention to connect specialty patients to the Quit line, which follows a very similar structure to BP Connect, our blood pressure intervention that I showed you. We assumed that we would have to get adoption approvals from about 5 or 6 committees in the health system based on our BP Connect experience. And then we ended up publishing a paper on stakeholder creep, which is if you don't approach your stakeholder engagement in a proactive way, you may end up with a situation where you are asked to check in with stakeholders who end up telling you you didn't need to check in with us. So we ended up having to go through 36 committees instead of 5 or 6 committees. And it led to some delays because we couldn't anticipate that. And so there was a period of 2 months where we weren't engaging, where we could have if we had known. And then we developed a checklist for stakeholder engagement that you can just look up our paper on stakeholder creep. Adoption is also thinking about who are the decision makers, because adoption is about the decision to implement? Who are the decision makers at different levels? And what information needs usually do they have to be able to make that decision? And what is going to resolve those information needs? And sometimes it's not only, there's a difference between need and demand, and you may need to align with existing demand in order to meet an unmet need. A great example of the distinction between need and demand, completely different constructs, is there is a need for interventions to reduce poverty. Are they widely implemented? No. There's not really need for another beer company, but there's a lot of demand, right? Like it's a multi-billion-dollar industry. So demand and need are different things. And if you're curious about how to create demand, there's an article about creating demand for unmet needs using agile storytelling. If you can't find it, you can reach out to me. So you can see that at each of those stages, the people, the users that we're designing for are different. And what we need to design for is different. Same for implementation fidelity, right? So for example, one of the things that we did in our BP Connect intervention is in engaging our medical assistants, we identified that one of the things that they were worried about is, and this was even more prevalent for Quit Connect, our tobacco cessation intervention, is I don't ask because I don't know what to do when they say, yes, I am ready to quit, because there is that option to ask not only are they a smoker, but are they ready to quit or cut back within 30 days? And I don't ask because I don't know what to do with that. We've seen that also with our urinary incontinence screening and management trial with Dr. Flynn and Dr. Neuner, that primary care teams don't ask about urinary incontinence because they don't know what to do with that. Well, one of the things that we did for our medical assistants with our Quit Connect intervention is we worked with them to co-design talking points that went right into the best practice alert that popped up to give them the reminder and went right into the order set that they could use to order follow-up. And we also had laminated sheets that further had common patient concerns and common ways to address those concerns. And we had those at the clinics. So identifying what are going to be some things that get in the way for certain users of being able to do the intervention actions as intended, and then designing for those things. That's where you can begin to think of implementation. It's not just we're gonna push out these things, is identifying needs and designing for those needs of different users. Same for maintenance, right? So one of the things that we found is that we were providing feedback on a monthly basis in person. It wasn't something that the local champion could do indefinitely because it takes time. And so after the first 6 months, we were able to identify what were the key things from that audit and feedback interaction, where the local champion was giving feedback to the medical assistants on how often they had remeasured, how often they had offered follow-up, and how often patients actually went to primary care for follow-up. We identified what was the key information, and we were able to turn it into a feedback email report. And we were able to maintain the outcomes of remeasurement rates and follow-up offer rates and timely follow-up rates and blood pressure improvements over, and by now we are at like 5 years, I think, despite no longer continuing the in-person feedback, right? So how do you design and redesign what you were able to do in the implementation period to change it to be able to continue in the maintenance? And then ultimately, this is all for who is the end user and are their needs ending up being met. Both the needs that we had identified for them, that we want them to get their blood pressure under check, but other needs too. Did we inadvertently introduce unintended consequences? And is there a way to anticipate that and or at least address that? So I want to see if folks who have been trying to use the worksheet have anything that they would like to share, or any example that anyone would like to share that we can work through together. You can get some free live coaching right now, and some of your colleagues may be able to offer some suggestions. I'll stop sharing so that we can do a little bit of FaceTime, and then we can go back. And if no one has a specific example, we can also go treat this as an open Q&A.
So I guess you're illustrating the difference between the need and demand. If there's no need for free advice, let's create some demand based on the content of your talk today.
Right, absolutely. So the one useful way to define demand is not what people say that they want, it's what capitals are people committing for the thing that they say that they want, right? So are people committing time capital, financial capital, social capital, anxiety capital, right? And in this case, people are not committing some of those capitals. Mainly it would be time capital, right? And anxiety capital, like being willing to put yourself out there, probably because of the hybrid format, probably because people don't want to be perceived as not knowing. And maybe people don't want to be in a situation where they talk through their problems in front of colleagues. So one of the ways that I would offer a nudge for that is, well, and the other thing is this is recorded, right? So people might be worried about that. So one suggestion would be, if you wanted to stop the recording and we can have a candid conversation about someone's problem. Another suggestion would be, is there anybody who would like to talk about their intervention, not as a way to say you've had it resolved or you haven't had it resolved, but as a way to say, nobody knows how to do these things, and the more brains we put together, the more opportunities that we can achieve impact together.
I'll make a side note. We had the J.D. Smith on campus last week. He was invited by Cancer Center, and I told him that I've been keeping this topic of logic models for implementation studies, particularly for him. So we'll get him in the lineup to do a talk so people can have a little bit of structured concepts from his mouth. That's one. Second, when you started to outline there the logic model elements from context, intervention, implementation strategy, going to outcomes, so forth, intervention and the implementation, I was thinking how, in fact, you may have different levels of design. You may have a primary or primordial design that you basically have a cloud that kind of overlaps with the context and the intervention and the implementation strategy. And then you may have one that is really related to adaptation and fidelity that is going in the middle over the intervention and the implementation strategy. But you probably also have a late one also, because you may have adaptations even for the maintenance phase, right? So you kind of,
As in the example that I shared, right? So we
right. I was gonna
redesigned.
say,
Yeah.
you co-design with the MAs in the OBGYN clinic. That may be very different from ENT clinic. And then how do you generalize that? How do you make that a sustained mechanism that is scaled up at the later phase?
Right. So absolutely, the reason why I was outlining both spectrums, right? The spectrum from effectiveness to impact with that right arrow, and the spectrum from context to outcomes with that logic model. Both of those spectrums are, in a sense, different milestones on that implementation journey. And our design journey is going to follow that implementation journey on those two sets of milestones, where from the gap from effectiveness to reach, there is a design problem to solve. From reach to adoption, there's a design problem to solve. Similarly, on the logic model, there's a design problem to solve in the context itself, right? You can be redesigning the context. And in fact, we had to have the EHR be changed. We had to have the medical assistants be given a delegation protocol, right? In some cases, you have to introduce incentives. So you can design and redesign the context. And in some cases, that interfaces with designing the implementation strategies. In some cases, you might be thinking of some of those components as part of your intervention. And then, as you said, the intervention itself can be designed, redesigned, and adapted. So one of the things that was in that example, by design, embedded in our approach, is that we had a engagement period between our kickoff and our go live. And then we had the first 3-month period. And then we had another engagement. And then we had a second 3-month period. And then we had our maintenance period. So we knew upfront that we were going to adapt. And to allow for that comparability that you're talking about, we said, okay, we're going to adapt, we're going to design, then we're going to hold for 3 months, and then we're going to adapt. And within that hold, there are troubleshooting, problem-solving things that occur, but as far as redesign, and then at the end, you've got the redesign for the maintenance, for the scalability period, for the sustainability period. But then there's also for scalability, one of the approaches that we're taking for that in our AHRQ-funded urinary incontinence trial across 40 primary care clinics is that by design, our intervention is organized as a menu of options that are adaptable. So we've got, it's an intervention for screening and management of urinary incontinence. We've got ask, advise, assist. And for each of those functions, there are different options that a clinic can choose and can adapt month to month during the practice facilitation engagements over the 6-month implementation period. And then by the end, we've got not only each clinic now has an adapted intervention that over at least 6 monthly iterations was made to fit in their local workflows, because first they tried to have the medical assistant do the screening before the visit, and then they realized they wanted to do the patient tries to self-screen with the portal before the visit, and then the medical assistant during the visit, right? So different configurations. And then each clinic ends up with their own unique adapted intervention, because you've got a lot of combinations, but also you end up with this framework of this menu of adaptable components that can then be scaled, right? So it's the middle ground between having a one-size-fits-all, same intervention for everybody, or we're going to do some extreme tailoring for every single clinic. The middle ground is what we're calling configurable adaptation. And we have a paper that we're working with Anna Bauman on related to that concept. So middle ground between intensive adaptation and no adaptation is this configurable adaptation where we're promoting adaptability across a menu of adaptable options up front. And of course, you can adapt beyond the preset options, but for the most part, the clinics found the options to be sufficient. So that's a way to, by design, set yourself up for scalability while allowing yourself to locally tailor.
Fantastic. Now, one observation from the implementation science world is sometimes the link between the context and implementation strategy. We tend to kind of be very empirical about what the implementation mechanism is going to be, and we choose a portfolio of strategies, and then we are very surprised that none of them worked or only 2 of them worked. So is anybody doing any rapid testing type of mechanism upfront before the intervention shapes up and the implementation strategy shapes up with specific mechanisms?
So we always do in our work. That's part of our engagement approach. I know that some of the really scientific mechanisms work is being led by Carol Lewis and colleagues, where they're working on the causal pathway diagrams. And here they're trying to identify universal mechanisms, right, across generalizable mechanisms. But I think that agile mechanism rapid cycle testing is, for the most part, the way to go on a project by project basis, while we have the larger science of mechanisms unfolding, and that's going to take years, right? But in parallel, I think every single project should assess, verify, and confirm the mechanisms that they hypothesize. I'll give you a very simple example from a series of events that we did last week in our center. So this is not for patients, this is for researchers in our center. We have about 30 researchers, faculty, as well as their teams. And we wanted to host an opportunity for them to connect, co-create, and shape research for impact, and how our center is going to develop offerings and services to support individual research programs, create new research collaboratives, and bring together this research community around design and implementation science. And we had previously done a 2-day grant writing retreat, and we had some data that not everybody is able to show up at the same time, and that people leave with not having done anything different from what they would do otherwise with working on their grants. So we designed an event that was Innovation Week. We had every day was 1 hour, an innovation hour from 3 to 4 on Monday, and then Tuesday, and then Thursday, Wednesday and Friday and Thursday, and then on Friday we had an innovation reception 3 to 5. We had innovation stations where we had different topics related to center development, research development, and specific research projects that people could brainstorm together with Post-its. And we had a survey at the end of each day, and we had team reflections at the end of each day, and then we made modifications for the next day. So we ended up with a 6-hour event that could have been a 1-day event, right? But by stretching it over 5 days, we ended up being able to do agile testing. And what we ended up discovering is that what we thought was going to be our core component, our core mechanism, which is these innovation stations of these flip charts and people putting up Post-its, was the least utilized, least useful component. People ended up converging not on the flip charts, but on each other, right? And they ended up congregating and talking with each other. And the thing that they said they wanted was a little bit of facilitated, structured conversation. And so we did that. We tried different things on every day. And each day we had feedback from the previous day. Now, the next time we do an event, it could be a 1-day, 6-hour event, because now we've tested a bunch of those mechanisms, and we can, you see what I mean? That's an example just from recent memory that's easy to conceptualize of how you could do the same thing in a clinic or in a nursing home or in a hospital prior to the trial.
Great example. Are there any questions online? From the room?
Good afternoon, Edmund.
Hi.
Hi, my name is Sid Singh. I'm responsible for quality, patient safety, etc. for the organization. First of all, I work with two colleagues, Sam Zelke and Amy Grasky, who apparently know you.
Fantastic. I have not spoken with Sam in maybe a decade. Please tell him I say hi. And Amy and I have been on panels together recently.
I will convey your regards. I'm keeping them very busy, and they don't have time to attend brilliant talks like this. No, I'll definitely convey your best wishes to them. My question to you is, from my vantage point, there are a variety of fields out there. There's human factors engineering, there's industrial engineering, there's implementation sciences, there's quality improvement professionals, and I can just go on and on. Within quality improvement, there are a variety of disciplines. All of them are fundamentally trying to do the same thing. They're trying to make, in my word, make patient care better. They're trying to make it easy for the practitioners to do the right thing. That's the fundamental. Yet I feel that because they label themselves with different specialties, they're not able to collaborate effectively and align around that singular aim that we are trying to make it easy for people to do the right thing. What are your thoughts about that? How do we get these specialties that are essentially trying to do the same thing but label themselves differently to align their efforts?
So you just described my career. I mean, that's why I have dedicated my career to being a boundary spanner and a bridger, not only across different disciplines like improvement science and quality improvement, implementation science, human factors engineering, and now agile science, right? Agile implementation, agile innovation. But also, so both bridging across disciplines and fields, and also bridging between different sectors, academia and health systems and industry, as far as our world is concerned, right? So we've got the technology vendors or the various industry organizations. We've got the health systems, and we've got the academic institutions. At least, and some of my work in assisted living, we also had various government agencies that were collaborating to develop a large-scale quality improvement data-driven initiative across 500 assisted living communities, so regulators and payers and so on. So bridging those different networks is critical, and it's what I've dedicated my career to. How do we do it? What I have done is translation of language, creation of relationships of various kinds, right? Informal human-to-human relationships, partnerships between organizations. I mean, me coming here from the Indiana CTSI and giving a talk at your CTSI, and maybe at some point visiting, maybe I'd be happy to come back for a part 2 or for a more interactive workshop. Those kinds of connections, we're not going to be able to resolve all of the differences because there are social network reasons why economics is a different field from sociology, just like improvement science is going to be a different field from human factors. But translation of terms, creation of relationships, and where there are complementarities, highlighting them. And the way that I've tried to do it is by delivering workshops and establishing collaborations in those different disciplines. As far as the academic to sort of real world, in my various fields, I've organized panels of embedded professionals. So for example, Amy and I have done a couple of panels together where there are people who are researchers and people who are in the trenches, exchanging problems, best practices, and opportunities. And it's a little bit early, but I've recently been contacted by a national organization about setting up a consortium of academic research institutions, health systems, and industry to begin to bridge some of those gaps that you're talking about. So stay tuned or reach out. I'd love to involve you.
I'll definitely reach out. I took a lot of notes during your answer. Thank you. That was very wise.
Thank you.
And since we have Sid on the call here, I'll take advantage of that and say, this is not a new problem, right? I mean, you find the example, and then you'll find that we had similar disorder, if you want. We start going deep, we start creating our own language and our own jargon, and we kind of become an academic, very scholarly discipline over time, and we kind of lose the connections with the contiguous or related disciplines. So the CTSIs, I'm sure everywhere nationally, it's the same problem. How do you bring together the community with the academia and the healthcare system in a working relationship that is not necessarily project-based but scalable? You start using the implementation science concepts to scale it up. And I'm also of the big believer that you need to have some local structures that will bring these people together. So that's why we advocated for the impact center, the CTSI, implementation, action, transformation. So you can bring folks from operations with folks from transformation with implementation specialties together. And this way, QI doesn't stay only QI, but is using the frameworks and the knowledge bases from the other specialties. Just my spiel about impact center that probably every trilateral system should have.
Agree 100%.
That is fantastic, Tavi. I'd love to talk about other ways our CTSIs can collaborate on things like that. I just put in a link in the chat to a paper that we've done for the human factors audience that begins to integrate the human factors perspective, implementation science perspective, and quality improvement perspective on primary care change in particular. But I hope, Sid, that could begin to answer some of the, at least translation and mental model pieces of what you're talking about. The rest is really what Tavi and I are talking about, which is the structure and process partnership building.
Absolutely. No, I took notes. I took notes on a 3-point plan to get collaboration done. So thank you so much.
Good.
Well, thank you so much. This was an outstanding session. Dr. Ramli, thanks for joining us, and we're looking forward for other collaborations in the future.
Absolutely. Thank you for inviting me. Thank you, everybody, for your attention, and please reach out in any way that is relevant for you, and hope that our paths cross in more ways than one.
Perfect. Thank you so much. Have a good one.
Thank you.